On page 46 and 47, you will see examples of vials and ampules, things that hold the medications until you draw them up. Vials are more expensive because they have 3 substances: glass, metal, and rubber. Ampules are cheaper. They're just little glass vials, and they have to be broken. But because they're easily breakable, there's a lot of loss in transit or in the med room, and so in America we use a lot of vials. On page 47, you'll see what's called a mixovial, and some medications will be in this. One example is Solumedrol, which is an IV steroid. The powder comes in the top of the vial, the liquid is at the bottom, and by pushing on the cap, it breaks the seal between the two, and you can mix them without the risk of introducing a contaminant when you're mixing it. Most vials are single use. You use the medication and discard the vial. Sometimes you'll see multi-dose vials. They're larger, and they're going to be used just for one patient. The days of using one vial for more than one patient, those are over because of infection control concerns. But it's not unusual for a person to have a vial of insulin in their med drawer, and you'll use that particular vial just for them over and over. A multi-dose vial has got to be dated when it's opened. Usually you can't use them any longer than 30 days, and they need to be cleaned off each time. On page 46, you see some rules of thumb about mixing 2 drugs in 1 syringe. Make sure you read those, and we will talk about that in an injection lab. The idea of mixing 2 types of drugs in a syringe, depending on their compatibility. Here we see pictures of ampules versus vials. Remember that depending on protocol, you might need a filtered needle if you're going to draw medication out of an ampule. One thing to remember when you're combining drugs in 1 syringe, they have to be compatible. So sometimes you'll see an anti-nausea medicine combined with a opioid pain med. And as long as you know they're compatible, it's fine. And it doesn't matter which one you draw first. Now, an exception to this is if you are mixing short-term insulin, shorter acting insulin with an intermediate acting insulin. You no longer see this as much as you used to because we have so many different kinds of new insulins out there. But you might have an older patient, maybe a home health patient or a patient who has had this as their protocol for a long time. Now, the main reason we teach you how to mix insulins is because they will still ask you questions about it on your testing and on ATI and probably NCLEX, and that's why we keep teaching it, even though you don't see it as much. At the beginning of my career, I did a lot of insulin mixing. By the time I was done working at the hospital, I couldn't remember the last time I'd mixed insulins. But your shorter acting insulin, usually called Humulin or Humulin R for regular. It's shorter, it only lasts for about 3 to 4 hours. It is a clear substance. It looks like water. On the other hand, because of the need to have larger protein globules to make it dissolve longer, NPH insulin or Humulin N, which lasts longer, it can last 6 to 8 hours, it's gonna have a cloudy appearance. And so when you are drawing it up, you have to draw up clear first and then cloudy. But to introduce air into the vial, you have to do cloudy to clear for air, and then to draw it up, clear to cloudy. I know it can be confusing. Just remember, if you're asked on a test or quiz, it's clear to cloudy, regular, and then intermediate. We will practice it in injection lab, and I do have an ATI video on it too. But for injecting air before the injection, it's cloudy to clear. For drawing up the medication, getting the medication ready to give to your patient, it's clear to cloudy. So air, cloudy to clear, administration, clear to cloudy. But we'll talk more about that. So let's talk about some of these different kinds of injections you might have to give. You might end up giving an intradermal injection. In this case, there are about 3 reasons you're going to give an intradermal injection. TB testing, which should be familiar because most of us have it done every year, and you might administer them. Allergy testing, if you've ever had the joy of having to have allergy testing, a lot of times they'll lay you on the bed and scratch your back with these substances and see if you react. But if they have to get a more accurate test and determine more clearly what you're allergic to, many times they'll do intradermal injections. And then if you have to have something numbed, maybe you're going to have a mole removed. Maybe you have to have stitches. Maybe you have to have a biopsy and a lesion. They will just inject lidocaine just under the skin layers to numb that particular spot. Sometimes, if protocol allows, when an IV started, a nurse will numb the outer layers, even if they can't really do anything about the vein itself. Now, the places that you can administer an intradermal injection, and an intradermal is just what it says, it's into the skin, usually under the epidermis. You can administer these intradermals on the inner aspect of the forearm, which is most common for TB testing, the upper back, and if needed, the upper chest if you don't have a bunch of chest hair. And this is listed on page 47. You can see where these spots are described. If you look on page 48, you'll see, it's figure 412, you'll see what it looks like to give a subcutaneous injection. It's just under the skin. You want to go in at a 15-degree angle, not absolutely parallel like with an IV, but slightly raised. You're looking to make a bleb. With TB testing, it's called a bleb, which is a little bump on the skin. Other times, you might hear it called a wheal, W-H-E-A-L. And usually when you're allergy testing or numbing, you're looking for a wheal. For equipment and technique, many times you're using a TB syringe because you can do very small increments of medication. The gauge should be 25 to 27. The length should be 3/8 inch, which is, 4/8 is a 1/2 inch. So this is just slightly shorter than that. So 3/8 inch to 1/2 inch. So pretty short. And then the amount of medication that can be put in is 0.01 milliliters, which is just like 1/100th of a milliliter, to 0.1. You don't want to go really any more than 0.1 because you're not going to make a nice bleb. It's going to be too much medication for just under the skin. And here you see a picture of that. And this is similar to the one in the book. 15-degree angle. You're just going under the epidermis. You don't want to go into the dermis. And when you inject, you should see a little rising bump on top of the skin. If you've gone too deep, if you've gone into the dermis, you won't get a bleb or a wheal, and you will not have an accurate test. It also shows where subcutaneous injections are given and muscle. So we will be talking about each one of those. So you just want to go 15-degree angle, just bevel of the needle just under the skin and inject the medication and see that bleb.